Hello. Good afternoon, everyone. Closer. Okay, thank you. Good afternoon. My name is M.SHAH, and thank you for having me today. It's been a real privilege and honor to come all the way from Los Angeles to share our work. I am what I would like to say as I'm not a physician, so that's one thing. However, I am, and that's, however, one thing I'm not is a doctor, but one thing I am is who we all are. So I like this philosophy of Ubuntu, that I am what I am because of who we all are together. And so that is going to be a theme in our presentation, because that is a theme of what we do back home, is how do we work collaboratively with different team members. I'm going to introduce to you work that we're doing with community health workers, which many of you probably know about throughout the world, especially in developing nations. They are leading the way in taking care of global health issues, what I like to call as local solutions to global health. And I don't know how to advance this. This one. So to start, I'm also here because of Dr. Heidi Beferuz. She is a pioneer in some of this work that we're doing in Los Angeles, and I'd like to tell you the story of how this all started, because she had worked with Partners in Health in Haiti and working with the HIV and AIDS population, and took that story to Boston, which then was translated to Los Angeles. The work that she was doing was at the time of the HIV and AIDS epidemic, which was rampant, and there was no resources, right? In Haiti, they didn't even have a structure for primary care health delivery in the communities that she was serving. And so what they did was they started by involving the community members, much of what we do in developing nations, using local resources and assets, hiring or working with local resources and saying, hey, how can you help us with helping the communities, help your neighbor, supporting them in accessing care, understanding that you don't have to die from HIV and AIDS. At that time, they didn't even have access to medications, nor did they have access to physicians. So what they did was they started there. They even deployed practices that are common in public health around DOT, direct observed therapy, and they found that much of that had succeeded. At the same time, what they realized was there was much community development going on. So as they did that, they not only were enhancing the access to care and medications, but they were reinforcing the community's ability to be themselves. So they were saying the community that was dying and feeling completely left out was now being brought to life. And so they realized that people were banging on the doors of PHI and saying, hey, we'd love to have access to services. So Heidi took this model of working with local resources and brought it to Boston. She established the Prevention and Access to Care Treatments program, and by addressing what they found was that the same thing that they were finding, that there was inequalities in access and HIV in Haiti, they brought that to Boston because they found the same disparities in Roxbury, which is one of the neighborhoods there, that Black women were dying 15 times higher from HIV. And why is that, right? So we have resources in the United States, especially in Boston. We have access to many doctors, all the resources and medications, and yet in our back door, people are dying. So where's the justice there is something that has driven much of my work, and certainly Heidi's work. So they took this model of hiring CHWs, and I'll tell you more about what the CHW does when I get to the Los Angeles model, but what they do is, in general, they support patients with medication adherence. So patients that might be going home. So in our clinics, in our primary care clinics, you hear things like, oh, the patient doesn't comply to what I've told them to do. We like to use the word adherence instead of compliance. The patient's a no-show. They never come to their appointments, right? So this concept of the patient is the one not listening to what I'm asking them to do is one that the CHW is helping to rectify. What we've seen also is that there's tremendous navigation in the United States. The healthcare system is incredibly siloed and very hard to navigate. So you don't even know where to go for what, and sometimes physicians, especially the specialists, don't always talk to each other. So you don't even have results when you have from one place to the other. The cardiologist doesn't know what the pulmonologist reports say. There's also a tremendous number of social barriers, which again, I'll talk a little bit more about as I go through this. But in Boston, what we found with the CHWs were important to overcoming things like transportation. Well, gosh, the patient didn't come as a no-show, but perhaps it's because they didn't know where to go or how to get there. They didn't have the means to get there. It might have had to take 3 buses and a train to get there after 3 hours. So what they do is this model, and so accompaniment is core to the CHW's role, and actually what Partners in Health has coined as one of their approaches as a CHW. It's accompagnateur, is I guess how they pronounce it. And that's essentially what the CHWs in Boston did, and again, what we're trying to do too. And that concept is one where I'm going to walk with you in your journey in health. I think someone alluded to that earlier today about understanding the experience, the lived experience of the condition in which you're living, and how that translates into your everyday life, right? So it's an incredible asset that we see that this relationship that's built between the CHW and the patient is one that then informs the provider in how they can change their treatment plan or even develop a care plan. Depression is also something that we found much greater in urban America than we found in Haiti. So the stories that we've heard from overseas is that they're so excited to get treatment, right? There's access to care, we want it, we're motivated to get it. What we found in urban America, unfortunately, is that the haves and the have-nots are so great, and perhaps this is the same in many developing countries, that some of these communities are so disenfranchised. So in Roxbury, Boston, it's a neighborhood where, like I said, the HIV rate is 15 times greater. Their people are dying. Same thing in there's types of statistics we see everywhere. As a result of that, there's tremendous number of disenfranchisement, and so there's depression and a lack of motivation, which also affects much of the illness that happens. And so trying to address that trauma and recognizing that trauma when we provide care is something that the CHWs also bring to light. So as I said, there have been some similarities and differences between Haiti and Boston. One, that they had addressed HIV and access, but the difference is, as I said, that CHWs were not, they had to address the spirit of the patient and really work in terms of the disenfranchisement. And so that's the same, what we brought then is this exact same model, or similar. We had to adapt it to Los Angeles. And what we did here, instead of working just with HIV and AIDS, and again, this work is being done everywhere in the United States around different issues. I used to work on asthma care and diabetes, and it's traditionally been done very conditions-focused. What we found in Los Angeles is that we were going to attempt to work with the most complex patients. So the highest risk patients in Los Angeles was a pain point for us. Our health system, I work at the county health system, which is a safety net hospital and multiple, we've got about 17 primary care clinics, and it's a network. And we serve about 10 million people, but the population is about 700 million patients annually. And so this highest risk patient pool are those that are dealing with the most complex health issues around. They usually have multiple chronic conditions, they usually have social stressors, oftentimes have behavioral health concerns that are being unaddressed or that are undiagnosed or unaddressed. So what we did was we hired community health workers. The health system decided that they were willing to invest in this workforce, and these are individuals from the community. So they're not trained, they're not licensed. Many of them have a lived experience, just like in Haiti and Boston. It was very important to find people that understood what the patients were going through. So we're working on the east and south side of LA, which the east side they're both poor areas. The CHWs, here's our first cohort that was hired. They serve as liaisons, linkages. They not only do navigation, but like I said, they go to people's homes and they help them with their medications. They help them, they help identify risk factors that may be associated with them in their homes. And this is the model. So this comes from the American Journal of Public Health, or the American Public Health Association, and it's bridging the gaps. The community health workers and patients are at the center of our work. I think someone also alluded to that. How do we make things patient-centered? So the patient is the crux of our work. As you can see, some of the different work that they do, and again, I'll talk about the details here, but they build individual and community capacity, which is essential. They bring back understanding of the community to the provider, which again is also critical. Many of the providers that we work with sometimes they're foreigners that come in because they're working at a safety net system. It's not the ideal scenario for most grads that want to come there. They also work with providers that may not understand or know even where the patient lives. So they may not understand that the patient they might be evicted, they might not have a job, they don't know how to get places. So the idea of a medical desert, but there's also food deserts, right? The doctor might prescribe the patient to say, we need you to exercise more and lose weight. How do I do that, right? So I can't walk around in my community because there's violence. Our CHWs come from these communities. They recognize and understand how to overcome those barriers. So what do our county CHWs do? They meet patients where they are, in their home, at community-based organizations. They work upstream. So what we've been talking a lot about is the downstream effects of the determinants of health. So they work upstream. They try to get to the root cause of why something is happening. So when someone presents with a particular condition, they peel that onion and they try to understand why it's happening. There's a lot of beliefs and norms that they understand from the community and help to change. So there's this community capacity building going on. And as I mentioned before, they accompany patients on their journey. They motivate and activate them. So yesterday we talked a little bit about this, how, again, behavioral health is, sometimes there's mental illness, but then there's the moderate pieces, and then there's all those things that you're afraid of doing. And many patients, again, if they're disenfranchised, or if you live in a community where it's difficult to, get up in the morning, it's difficult to pay my bills, it's difficult because my children have a developmental health issue, or I'm stressed because of not having enough food. Those things are compounded, and then having this motivation and then to take care of my diabetes is often not necessarily the top priority. So there's this community capacity building that we've built into our work, which is new, I think, for the traditional healthcare system, where we're not just working on treating the body, the physical illness that's here, but also the healing that goes on emotionally and physically as a result of where I live. And then, of course, then there's workforce development, which I'll get to in a moment, which is one of our main goals of this healthcare, of the workforce development. So this concept, this is something that we've been talking a lot about, I think, and I'd like to summarize it by saying that, about 50% of what we see is a result of health behaviors, what the individual does, and clinical care, what's going on in the medical system. However, the other 50 is a result of where we live. So health, as Dr. Ribeiro just mentioned to me on our break, that health is not a medical issue. It is a result of everything that is around us, right? So it's not only health that causes these poor health outcomes and poor quality of life. And that is what the CHW is able to address, and something that LA County has really been shifting its focus on. So we're looking at the environmental health, what's going on in people's communities. Do they have, I think someone talked about poor air quality. Do they have mold in their home that's then causing their child to rush to the emergency room because it exacerbates their asthma? The social and economic factors. Just the other day, someone told me that, well, gosh, my CHW went to their home because they were following up on their diabetes medication, but they were being evicted from their home. So I didn't get a chance to talk about the diabetes. So how does the CHW work? They have to take care of the whole person. They're identifying issues that are going on in the patient's lives that may impact, and likely does impact, the prescription that the physician asked them to do, right? So there's a reason why these checks and balances in vulnerable populations, sometimes the patient isn't always able to prioritize their physical health because of all these other things that impact their lives. So as far as impact, we have seen improvements, just like in Boston. We saw tremendous improvements in outcomes in terms of, controlling levels of CD4 in HIV patients. For us with diabetes, we've seen control of A1C levels. We've seen improvement in adherence to medications, that patients are actually following up on primary care. In fact, we saw, as far as utilization goes, tremendous spike in primary care use instead of urgent care and hospitalizations for preventable conditions, which is huge for us because that's where the cost issue hits the county, and that was something that the reason why they did some of this. So there's that economic driver. And then there's also this, we've also identified gaps and challenges that we see in our system. So a safety net system as a structure, we found out that moderate behavioral health issues and mental health issues is not being addressed. It just kept recurring that those were the patients that even our CHWs were having a hard time navigating to services. So all of a sudden, as we've introduced this new resource, we've not just been helping patients do better, but we've also uncovered very specific challenges in the actual delivery system. So that's been incredible because now we can bring that to the attention of those that actually do the structural and system changes and how can we make those changes. We've also seen improvements in provider-patient communications. Our providers are happier. They tell us that working with the CHW saves me time. I'm able to find out, like patients come in, we have a protocol that was developed that does pre and post-test, or pre-visit and post-visit debrief. So the pre-visit is how does the CHW work with the patient to help them outline their questions and prioritize what is going to be answered in those 15 minutes that the patient has with their physician, right? So how can I really get targeted healthcare? And what questions can I then wait to ask my nurse? Or what questions can I ask the next time I go? There's team-based decision-making and psychosocial understanding of the lived experience again. So providers have told us that, I had no idea that this was happening in their patients' lives, that I couldn't just tell my patient to lose weight. I realized that, they weren't eating differently because of these reasons. Because our patients trust us, trust ICHW, they trust me. So there's solidarity building that was going on because of the CHWs. Again, there was, initially, I don't know if providers recognized that there was a disconnect. They were just frustrated that the patients weren't listening to them. And so we saw that repeatedly. Like, I'm so tired, I'm so busy, my patients are, I'm frustrated with trying to serve these patients and they won't listen to what I'm doing and what I'm telling them to do. So that was, again, something that we recognized that the CHWs were able to bridge some of that and help patients be better patients, in terms of like being more active and being proactive in their role, and then providing information to the provider, the healthcare provider, who could then build that into their treatment plans, right? So it was another factor that one included in their, the prescription that they developed. And we kind of call this turning of the traditional paradigm upside down. So the traditional healthcare that as patient comes to you as a physician and says, I'm feeling these symptoms, please treat me. And so the provider then gives them a prescription of what to do. What we're finding is that if we start to think about things differently by shifting it, the paradigm turns it upside down because the patient is now the one driving and leading what needs to be done. And that's surrounded by this community support and the perspective of the community of where I come from, because the patient isn't just their illness. They are what they came from and who they have lived that traumatic, whatever, if they had trauma in their experience as a child or whatever had happened to their families, all those factors influence what happens to them. So I think we were going to show, one last,
Llego yo acá y la primera impresión fue, pues, ¿qué hago? No sé el idioma, no estoy con papá, ni con mamá, ni con mis hermanos. Comencé a estudiar clases de segundo idioma, el lenguaje inglés, por la noche. Fui descubriendo el sistema y de ahí fue donde me di cuenta que sí podía estar en un colegio. Pues con todo y mis miedos, me enrolé en la universidad y me gradué el 2004 de psicóloga. My name is Clara Luz Núñez. I'm a community health worker in the Los Angeles County Department of Health Services. Yo nací en México, en el estado de Zacatecas. Ahí me crié desde que nací hasta los 21 años que me casé. Vengo de una familia muy grande. Papá y mamá tuvieron 20 hijos juntos. Yo tuve esa fortuna de tener un buen trato de papá y mamá porque me enseñaron a ser madre, me enseñaron a ser hija, me enseñaron a ser hermana, cariñosa, amorosa. Pero más lejos de eso, me enseñaron a respetar al ser humano. Papá ya tenía 89 años cuando me lo traje y mi mamá tenía 78 años. Bueno, la razón que yo decidí traerlos fue porque mi papá tenía Alzheimer's. Y yo le sugerí a mi mamá que yo quería cuidarlos. Papá duró buenos años y murió con Alzheimer's. Y mi mamá, a los 2 meses de haber fallecido mi papá, le diagnosticaron cáncer en el hígado. Entonces, es como que todavía no lloraba la pérdida total de papá cuando ya estaba la de mamá. Entonces, mis papás vinieron a hacer ese rol tan importante en mi vida, porque a través de la enfermedad de ellos, yo pude divagar el sistema. A través de ellos, yo puedo dar calidad a mis pacientes. Doctora. ¿Cómo la ve?
Muy bien.
¿Qué quiere que le pregunte a su doctora?
Que soy de los ojos, que me mande algo.
Ah,
los ojos,
bueno.
que mande algo para los ojos.
Sí, muy bien. Esas miradas tiernas, esas miradas donde depositan esperanza en uno, esas miradas donde te dicen, mi vida está en tus manos, ¿en qué más me puedes apoyar? Y eso me hace fuerte para darles calidad, porque no se vale que nada más venga a hacer las cosas por deber, sino por amor.
We utilize community health worker a lot in conjunction with all the other healthcare team to try to get them to work with the patient more directly.
Hola, Alfredo. ¿Cómo estás?
Because the community health workers seem to have a different kind of relationship with the patient where they trust them better.
El hablarme, escucharme y orientarme.
They live in this area, they understand their cultural, their beliefs, so that help a lot in terms of relaying that message to the provider.
The patient is mostly dizzy. Lo importante del programa está diseñado para que trabajemos en equipo. Yo voy a sus casas, reviso medicamento, si les falta comida, si les falta vivienda, transportación, si les falta ayuda monetaria, que yo les revise documentación. Entonces, esa parte que yo colecte en el hogar, vengo y se la comparto a la doctora. Community Health Worker lo que sí ocupa es esa compasión, es esa empatía, es ese deseo de corazón de poder apoyar al ser humano.
Contesta, informa, enseña, es una lindura.
Me siento muy contenta, muy feliz de yo poder ser parte del Community Care Program porque tiene un propósito fenomenal, fantástico.
Thank you for that. That was an add-on to our presentation. I'm so glad we were able to share. Those are, I mean, our CHWs are inspirations to me and really incredible. But I wanted to share that because it also highlights that we're not just doing this because we're introducing a new workforce, but we really want to build that capacity in the communities by raising and allowing, creating job opportunities for people in communities that don't always have that. And so the transformation that occurs not only with our patients in the health system, but also in the lives of the individuals who we hire is phenomenal. And every single one of them has their own story of how they've changed their lives, you know, and because they themselves have also experienced things from the community and had to overcome that in order to get to a place to then support others. So some of the challenges, I wanted to spend, I think I have 4 more minutes. Okay. To wrap up with some challenges and some of the issues that we have in terms of how we can maybe adapt this elsewhere and what we've learned from it. So CHWs are viewed as lay people, and so one of the challenges that we've seen in the clinic setting is that nurses and providers don't always accept them in terms of, because they're not licensed and you're stepping on my toes, what are you doing here? That task shifting sometimes occurs, which we very much are not in favor of, because it's not that they're just taking over someone else's job, they're actually bringing in a new resource, like they're bringing in new information and addressing factors that weren't being addressed before. There's the system readiness of having new responsibilities and staffing models that need to be developed. There's also the expectation oftentimes that you need to show a quick return on investment. And when you're working with people's lives and seeing suffering that has occurred over generations, that doesn't happen right away. So if we are thinking about this, again, CHWs are local solutions. They are in fact experts in their area of work, which is around the community, and they bring that breakdown of the social capital that we see that has maintained this structure of disconnect, this hierarchy that we have in healthcare, particularly in the United States. And so they are a means of breaking that down. They are deployed, as you know, worldwide. And what we see is that along the continuum of care, we've seen opportunities in the United States where CHWs are being used at community-based programs for primary prevention, but also then through screening and self-management. And in Los Angeles, we're working mostly around case coordination and complications, so around this, like I said, at the end of that work, more downstream and less upstream. However, there are a number of upstream models that are out there. Strategies for implementation. If you were to engage leadership as champions, one idea would be, and this is something we did too, is to find those doctors that are well respected and doing good work that might be able to model how to work with a CHW, because their successes would then be translated elsewhere and seen as something that, oh, I can do that too. We want to model team-based practices and coordination of care, tackling upstream and downstream, as I mentioned, and documenting and spreading this well. Engaging patients is something that we've also talked a lot about, in having advisory boards from the community, like having patients actually be the ones that are directing how providers can do things differently. We also structurally need to, like I said, flip things upside down, that there needs to be the political and organizational will to do this, and if that's not there, it will not succeed. That, you know, we have global payments now, so there is a financial incentive in the United States to make this happen. And also, again, reversing the work. So, you know, we received a big grant from NIH at one point and decided that, you know, we need to give this money to the communities and not necessarily keep it for the health system. Workforce strategies are still being developed both in the community, throughout the United States, in terms of developing certifications, how do you standardize this practice, and continuing to share this. So solidarity is absolutely necessary. And I just wanted to wrap up with, you know, a lot of this work, again, is being driven by inequities in health that we see. And so if these inequities continue to persist, how are we going to, if we're not going to address them, we won't be successful. So a true measure of our society can only be defined by how it treats its most vulnerable populations. So thank you, and sorry to go over.